Assalamualaikum. This is a slide session for hepatobiliary and pancreatic pathology. And the first slide is a biopsy showing a non-alcoholic steatohepatitis. It is difficult to differentiate between alcoholic and non-alcoholic fatty liver disease as they share similar and overlapping morphology. Non-alcoholic fatty liver disease occur without significant alcohol consumption. As much as 5% of liver parenchyma may show lipid accumulation or steatotic changes, as it is only considered pathologic if the steatotic changes occupies more than 5% of the liver parenchyma. Over here, we can appreciate that the changes are up to 90%. And this is a strip of liver showing a presence of a portal tract over here. And at the bottom is a central veins or terminal hepatic venules. And in between is a liver parenchyma, liver lobules, part of liver lobules. And we can appreciate that the steatotic changes in this strip of liver biopsy mainly more apparent at the perivenules or at the zone 3 area. Higher magnification showing portal tract. It is composed of portal veins, terminal afferent portal venules, and terminal hepatic arterioles, and also a bile duct. And over here, we can appreciate the spectrum of the steatosis changes because we know that in adult, the steatosis commonly begin in the zone 3 hepatocyte. This is different contrast with the zone 1 steatosis in viral hepatitis C or the pan-acina pattern seen in pediatric non-alcoholic fatty liver disease. Lobular inflammation in patients with steatohepatitis is usually mild and consists of mixed acute and chronic or mainly chronic inflammation. Scattered lobular microgranuloma and lipogranuloma can be observed. Microgranuloma is an apoptotic hepatocyte that is surrounded by the inflammatory cells, and lipogranulomas is a single fat droplets or it can be multiple fat droplets that is surrounded by a mononuclear cells and or eosinophils. Higher magnification showing a better view of lobular inflammation. There is a focus of inflammatory infiltrates within the hepatic parenchyma, and these focus are forming both microgranuloma and a lipogranuloma. Quasar view showing a presence of the microgranuloma and lipogranuloma, in which we can appreciate the eosinophils, neutrophils, and chronic inflammatory cells, such as lymphocytes over here, surrounding the apoptotic hepatocytes as well as lipid droplets. Going to the zone 3 nearer the perivenous area, in which the macrosteatosis in the form of large droplets and small droplets are more apparent. To diagnose steatohepatitis, we need both presence of steatosis as well as evidence of hepatocyte injury. And injured hepatocytes may appear as a balloon hepatocytes, or apoptotic hepatocytes, or also called as acidophil bodies, or any evidence of a lytic necrosis, in which this is represented by a foci of spotty necrosis of the in which the remnant of the hepatocytes underwent the lytic necrotic process. And hepatocellular ballooning, or hepatocytes ballooned cells, is they appear as an enlarged cells with reticulated cytoplasm. They may or may not contain fat droplets, and they are located predominantly in zone 3. This is one example of ballooned hepatocytes. We can appreciate that this hepatocyte is larger than the adjacent hepatocytes, and they are surrounded by these inflammatory cells. And this is another ballooned hepatocyte with poorly formed malaridang bodies within the ballooned hepatocytes. And when they are surrounded by the inflammatory cells, we call this as a satellitosis. Our second slide is mucinous cystic neoplasm of the liver. Microscopically, mucinous cystic neoplasm are typically single and exhibit multiloculation surrounded by a thick fibrotic capsule. And histologically, here we can appreciate that this is a multiloculation, multiple locules of the cystic lesion, and they are lined by mucinous type epithelium. Over here, we can appreciate that the lining epithelium is consist of tall columnar cells with abundant apical mucin. Some of them appear ciliated, and the adjacent locules, the adjacent cyst, the adjacent smaller cyst, they are lined by the cuboidal cells lacking obvious mucin. High magnification display columnar cells with pseudo-stratified bland nucleus and apical mucin. The adjacent stroma show a distinctive pattern of hypercellular spindle cell stroma, what we call as a ovarian-like stroma. And this is a diagnostic prerequisite for a mucinous cystic neoplasm. And as we go along the fibrous wall, the wall of the cyst, we can see that there is an area in which increase in proliferation. The cells are more exhibit stratification, and cytomorphology display low-grade dysplasia in which the cells the nucleus are larger, and they are more hyperchromatic, irregular nuclear outlines, as well as increase in nuclear to cytoplasmic ratio. The third case is an intrahepatic cholangiocarcinoma. Patient with primary sclerosing cholangitis has a significant increased risk of developing cholangiocarcinoma. In this strip of liver biopsy, we can see over the top of this biopsy, it is a remnant of liver parenchyma, and at the bottom is infiltrative malignant epithelium, and in between this, at the middle strips, we can appreciate the presence a significant amount of dense fibrous stroma associated with a desmoplastic reaction. Let's get closer to this area. Here we get to see the hepatocytes in which they are arranged in one cell thick cords and separated by a slightly widened sinusoid. The hepatocytes is a polygonal epithelial cells with a small round centrally located nucleus, and some of them show binucleation. This is normal with increasing age. At the other end of the strip is the malignant epithelium. Cholangiocarcinoma, usually well-differentiated adenocarcinoma. It shows a well-formed tubules or gland with a mild cytologic atypia. However, in this case, we can see that the cells, the malignant epithelium, are arranged in a nest, in solid, in lobules, and a single cell pattern, lacking any glandular or tubular formation. This is a poorly differentiated cholangiocarcinoma, and the cytomorphology exhibit large cells with a vesicular nuclei, open coarse chromatin pattern, and they show an increase in the nucleus to cytoplasmic ratio. They are poorly differentiated, lacking any glandular architecture, no tubular formation. They are arranged in this nest, lobules, and cords, not forming any glands, and the cells show severe atypia. Inflammatory cells and desmoplastic trauma can be seen at the advancing age of the tumor. Here we can appreciate the presence of breast mitotic activity. In one high power view, we can appreciate a lot of them. Next case is a solid pseudopapillary neoplasm of the pancreas. We can appreciate that they are well circumscribed, even though sometimes it can be infiltrative, well marginated and separated from the adjacent normal pancreatic parenchyma. This is the tumor. And the adjacent pancreatic parenchyma is composed of the over here lobules of an exocrine component, consist of the acinus that are lined by the acina cells, and there is presence of interlobular duct. The basic architecture of these neoplastic cells in solid nest and lobules, however, particularly at the center of the nest or lobules, they are discohesive. And due to this cohesiveness, they impart a pseudopapillary architecture. This is an area showing a pseudopapillary architecture. We can appreciate that they are actually in nests and lobules. However, the cells at the center of this nest and lobules are degenerate and discohesive. Therefore, they are forming a pseudopapillary architecture. If we go and see other area, there is neoplastic cells arranged in a nest and lobules, and in between these nest and lobules, there are numerous blood vessels. This area shows adjacent pancreatic parenchyma near to the cyst. We can appreciate here there is a lobules of an exocrine component as well as a pale island of an endocrine component. The exocrine component is composed of the acinar cells, again lined by the acinar epithelium, and the pale island is an islet of a Langerhans. Closer view of both exocrine component and also the endocrine component. Pancreatic duct, and adjacent to this is the cyst wall, and we can appreciate that the wall are denuded of the epithelial lining. No obvious epithelial lining. Most are inflammatory cells as well as the necrotic debris and blood clot. However, when we move and go along the cyst, we can see that the cyst wall is in relation to the ductal system. Therefore, the differential diagnosis include intraductal papillary mucinous neoplasm as well as the retention cyst. And what more important is, we need to find if there is any dysplasia or any invasive components, and extensive sampling is mandatory.